My name is Nong Vang. I'm a student with the DNP program here at FNP. Today I will be presenting my project, my final project here. Um, it is called Telephone Reminders Improve Appointment Adherence in an Injection Clinic. My asterisk started background here is when the background is an injection clinic that I'm working with continue experiencing a high number of no-show appointments, resulting in patient late for their scheduled long-acting injectable antipsychotic drugs. And the purpose of this project is to implement telephone reminders to patients within 24 hours of their scheduled injection appointment um, for a 2 month period to see if that will improve the clinic's data of no-show. The method is we're using a z-test to calculate by comparing with the pre and post-implementation proportional group. In the pre, we'll talk more about this later, but the pre is consists of before the implementation was involved, and it was taking data was from January to April of 2023, while the post is after we implement or while we implement. This is consists of 2 months of October, November 2023. Results show a z-score of 2.6050 and a p-value of less than 0.005. So in this case, we are rejecting our null hypothesis, which is stating that there is no difference, or stating that our implementation does not improve the clinic's show and no-show appointment rate. But we're going to reject that because our alternative hypothesis is right and valid. So in conclusion here, we find out that we should a low p-value or finding insignificant, statistically and clinically significant. So phone reminders improve patients' adherence to their injection appointments if the phone is making it within 24 hours. Introduction. The problem is no-show appointments is an ongoing issues in healthcare organizations, including the injection clinic. When the patient is no-show to the scheduled appointment, they didn't cancel within the period of time that can allow other people to schedule or replace that missed appointment. We can increase healthcare costs, workload for provider and the rest of the people. And most importantly, it can impact patients' health outcome as well. The background knowledge and interest. The clinic experienced about 20 to 30% of show appointments monthly. Patients late for their long-acting injection or lie, in short, which require them further evaluations by the prescriber, which is increased healthcare costs, increased time workload, and increased hospitalization risk. Because when you delay administration of the injections, it increases psychosis relapse, right? And then psychosis relapse can cause hospitalizations. So I'll talk a little bit about the lie injections here. It does stand for long-acting injectable antipsychotropic. So it normally prescribed for patients who are known to be in compliance with medication. For example, they can either take Abilify or generic name Abiliprazole every day, a pill daily, but these patients are known to be non-compliant. So sometimes the prescriber will put them into a long-acting drug injections, which is every month injections of a huge dose. So we're going to an intramuscular and will last about 4 weeks, and then the patient have to come back for another injection every 4 weeks to consider compliance with the medications. Sometimes patients find this is convenient, though it is important not to miss the appointment at all, because if you miss one injection appointment, it could mean so many daily doses in there, right? Our specific aims here is to implement telephone call reminder within 24 hours to patients who have a scheduled injection appointment, and we're hoping to increase the patient's adherence to their visit when we make this call. The project aims to improve patient adherence to their appointment and medication and improve overall health. Literature synthesis, it's when we review what has been done in the past regarding to similar situations and have if there's any studies have been done in show improvement. Yes, there are plenty of studies that have been done and they have similar problems. Like I said before, no shown to a medical appointment has been ongoing problem over the nation. So the three main themes we identified during literature review will be how similarity these articles have are the effects on no-show appointments, the intervention used, which is relating to use of reminders, phone call, or even text message, so on. And then the outcome of the intervention normally is reduction in no-show rate. So the article is pretty consistent. And in critique, today we'll talk about strength and weakness. The articles all show improvement in appointment adherence of different facility. Excuse me. I won't go over this too much. You can come back to look at them. And they also have consistent on demographic studies, age, gender, diagnosis, gender, education, and income that may contribute to the data as well, which is similar to what our project is going to be focused on as well as part of a discussion. And our weakness will be most of these studies or articles will state that health no-show to a medical appointment increase healthcare costs, increase revenue, workload, and so on. However, there isn't a particular study or data on how much it is. There's one study talking about a few $1 million, but that's it. So if there will be more study that could prove of that, would be great. And in the theoretical framework for this project, we are using NOLA's Pender's health promotion model, which is defined as a social cognitive theory that develops activities or actions that improve patients' health outcome and well-being. Okay, and then here is our design, our methods here. This study is using quantitative design in nominal order. We are using number, a comparison between pre and post implementation period. We want to see if there's positive correlation or association between the two groups after the implementations. The stakeholder in this project will be healthcare director of the facility or public health district that currently the clinic is under. We're also involved managers, psychiatrists who very much into making sure patient receive the prescription on time, and nursing supervisor. Simple include our data collection instruction sheet, which I'll show in a little bit here. Data manually retrieved from a system called NextGen, which is work with the clinic. Data periods consist of 4 months pre-implementation and 2 months post-implementation. These are our two proportional group that we're going to compare. And then we have the data won't be in any terms or any other than all demographic study, right? The data will be in numeral order, which will be total scheduled appointment, total number of show appointment, and total no-show appointments from each period. So we won't use any words at all to describe unless it's a demographic data, which consists of ages, gender, races, and geographic location. We want to know if these factors also impact how the patient adheres to their appointments. And I won't go over this too much. You can come back to it. These are my instrumental sheets that I use for data collection. Continuing method or analysis plan, we have independent variables, which independent is phone call reminders. Dependent is the number of show and no-show appointments. right? So I just want to be clear, our hypothesis statement here is stating that there will be a positive associations between phone call reminders and appointment show rates in the clinic. Therefore, meaning if there is that phone call happen, then patient's gonna come. That's our argument. So we expect an increase from when there's no phone call implementation. The Z test with two different independent proportion with the chi-score is the statistical tool that we're gonna use, and this can be run under Microsoft Excel program sheet. The budget for this is very little to none at all. The period, implementation period is 2 months. We have about 90 to 100 appointments. The cost will consist of stuff like printing material, cell phone usage, and utility, and very minor thing that estimate about $246,000, which is does not require any grants or any funding from anyone. Protection human subjects. This project is complete without disclosing of patient's information or the clinic information, so we do not violate any confidentiality or HIPAA. Therefore, we don't really need IRB approval or consensual form from the patients because we don't use information. We collect our data as a number of appointments only. So this is also considered a quality improvement project that is being reviewed by the Maryville Quality Improvement Team, which is approved. And then next is our findings here, validating reliability. The statistical method that used in this project has been reviewed and consulted by Dr. Mark Poles, Maryville University statisticians. He is very well known for statistical work. Other studies similar situation have also used a z-test to calculate data consists of pre and post implementations with very significant results. So most of the literature that I used to support this project have used z-test to compare their study because they're doing similar as what I'm doing right now as compare pre and post. Data quality and adequacy. We manually extract data from the next gen system to avoid error because there are special appointment circumstances, such as we have appointment that is scheduled to be called within 24 hours, but then those appointments were canceled by the patient called to cancel appointment before 24 hours, which is consists with the clinic protocol. So therefore, we cannot blame the patient of not complying with the appointment because they cancel it before 24 hours. However, because it's before 24 hours, regardless, we're not gonna make the call until it is within 24 hours of the appointment, which is consists with our PICO statement. So that way we have to manually extract these data to avoid this specific errors because the next gen system, it won't be able to spatialize or filter stuff like this. So we have to like look through each appointment to make sure it is legit and not being canceled already. So the data is very adequate. Ethical considerations, we have so much team involvement, including nursing, supervisor managers, psychiatrists, even the data analyzed. All data sheet contain no confidential information, no printout were made, and if there is, they will be shredded right after. Data consists of numerical, security intact, data keeping it locked and protected username and password. Computer in that computer is keeping inside nursing office, which is locked, and the whole clinic is again locked as well. So there are multiple locked level here. Another more morality ethical consideration the team going through was like If they could not get a hold of the patient for the first time, they will continue multiple attempts until the patients call back or get a hold of them. Or they could go through like another prescriber, for example, a therapist who's seen the patient the day before, could help remind the patient as well. So the team had huge dedications. Quantitative method here, we have data finding, we have we're using the z-test, upper tail test here. And I'm just gonna explain the chart a little bit here. This is our data, the raw data finding here. We have total schedule appointment, total show, total no show, and this is just like the ratio of the show and no show. So you can see pre is we're at 0.712 for the ratio, for the show ratio. And then post implementations, we have 0.864 show appointment ratio. That's a huge increase. And then here is you would expect a decrease because this is a no-show ratio. And then this is the intermittent calculations here, or hypothesis difference is 0, right? This is our null hypothesis stating that, oh, our implementation will not change anything. But our alternative or main hypothesis stating that our implementation will increase the number of show appointment. So the level of significance for us is 5% here. In our intermittent calculations here again, just go over the proportions. The most important are the test statistic score, and then our p-value here is 0.0046. We're looking for anything below 0.05 or below a significant level, which is very, very significant here. It shows that our project is both clinically and statistically significant. We can reject our null hypothesis and approve our alternative or main hypothesis that our implementation is significant. It improves the show rates in the clinic. And then this one is just a difference between two proportion with study power. I have a 85% power, which is very, very high, very significant to argue that if anyone is using my project as a platform, they can be confident 85% that it will run data similar and it will show significance. And just briefly talked about demographic finding here. We have age, gender, race, and geographic locations here. You can see the blue is the no-show for pre-implementation, and the orange is the no-show for post-implementation. Demographic finding is a little bit different because we look at the other way around. We look at the no-show perspective. You can see that you can expect the no-show to be higher and the orange to be lower because that's post-implementation. So yay, our result is very significant even with the demographic finding. And then the outcomes is as expected. We expect that our no-show result will decrease and our show appointment will increase, right? So we are achieving our expectation, improving clinic's appointment adherence. The project results show that the project intervention phone call reminder made to the patient within 24 hours of their scheduled injection appointment was adequate. The calculation between pre and post implementation show more than 10% increase in the number of show appointments. The facilitator and barriers we have are our receptionists, providers, nursing staff, and an important person or EHR capability analyze who's kind of point out in the next gen system what I can retrieve and not retrieve, how can I filter things out, and she's kind of helped me go through the manual extraction, so that's very helpful. There is no significant barrier identifying this. project. Very minor one is when the patient did not answer the call, and call have to be, we have to either mark it as voicemail, but we still count as our total or reminder. However, because we did not cut between that, we only count the one that answer, we count all that we call. Unintended consequences will be staff continue making phone call after implementation period. This is a good, a positive consequences. I wasn't expecting staff to continue making those phone calls because our project can show results so quickly. You call them today, if tomorrow they come, right? So, or you call them like earlier today and later today they come on their scheduled appointments. So with this, the staff are very happy with the people who show up for their injections appointment, and staff just having to continue without needing further assistance. Discussions. There's our strength. We have team establishment, teamwork. Staff continue making phone call after completion of project. Project has multiple opportunity to provide update to clinics people, including psychiatrists, supervisor, manager, nurses, and other staff. Project finding provide additional awareness and consideration when psychiatrists prescribe the medications. Project serve as a platform in trial demonstrating the efficacy of the implementation, and the clinic received multiple benefits. Primary literature used in the study shows showing results for primary or medical facility and mental health facility as well. The lamentation we have pretty few here. There are numerous appointments were called to be canceled, and I think I talked about this earlier, by the patient 24 hours before the appointment, which is complying with the clinic's policy, right? So this one we cannot use. We have to accept that the patient is compliant. And again, it does not impact our overall data because we cannot use this regardless it's before 24 hours. So we will remove the patients from our data. But however, this cut down our data a little bit, and impacting staff adjusting post schedule as well, because the staff, they kind of plan ahead. The clinical scheduling system could not generate automated data with unique customs. Therefore, data was manually extracted. It will be a faster process if we can automatically does that. But however, everything works out. Implications for nursing practice. The calling and cooing increased clinical practice in terms of ethics and morality. We show them that the patients feel like the clinic care about them. So they're more likely to adherence to our treatments, have a good relationship with the clinic. An increase in appointment show rate means more patients complying with their appointments contribute to their overall health and health outcomes. Compliance with medical appointments foresees many positive aspects of health outcomes for the patients. In future research, due to the simplicity of the project's implementations and also the no cost other than the teamwork, right? It is likely that the project will be considered for future clinical practice within the county health departments, because the injection clinics right now is a subclinic of the public health sectors. So most likely the county will consider this because it does not cost much. It costs teamwork, however. The project finding will serve as a platform for other organizations to implement similar continuous quality improvement project in their facility. We're confident in saying this because the clinics we have such a high number of power, finding insignificance in both clinically and statistically. The whole project required minimal to no expense and was easy to initiate. However, the project required good teamwork, encouragement, and follow through to successfully keep it a continuous quality improvement project. And in our conclusion here, again, our project is just to improve the clinic's show appointments rate, because it's been an ongoing problem, not just the clinic, but many health organizations. And our project show that patients, implementation of telephone reminder within 24 hours increased the clinic's number of show appointment within 2 months when compared to 4 months of no implementations. The plan for sustainability will be come up with the designated person to manage and lead, follow through with implementation process, continue making changes to overcome challenges, continue presenting positive findings, providing support, education needs, incentive for team members. Plan for disseminations will be ensure stakeholder knowledge the clinical problem. When the stakeholder know the fact that just not make up, but you show them the number that not gonna lie to them that hey, your clinic is really going through this. There's no alternative way that they can turn no from it, other than what can we do to improve, right? And then you suggest something for them like this project example that does not cost them anything. So what are the chances that they're pulling back from this? Suggestion include the project and its finding, discuss project's finding in leadership meeting, and then ask for a future date to further discuss the project itself with them. All right, and these are my references for the PowerPoint here. Thank you for listening.